So good afternoon. So first I'd like to thank the organizers for inviting me, and thank you for the kind introduction. I'm going to change the title a little bit to, instead of another case of optic neuritis, I'm going to talk about another case of functional visual loss. So it's a very simple case with 1 or 2 learning points, which I hope you'll be able to take away with you. So I'll try to make it interactive. So just before I start, may I ask how many of you are neuro-ophthalmologists amongst us? Okay, if you're a neuro-ophthalmologist, you are not eligible to answer any of the questions coming up because it will be too easy for you. So, of course, no interest. So, I have a 55-year-old female Chinese accountant who was referred from an outside center to our center with both eyes visual loss of unknown cause for a second opinion. So she presented with visual loss in her left eye 3 months earlier with a sudden whiteout and painless, and the same thing happened to her right eye 2 weeks afterwards. So she was of good past health. There was unremarkable family history, social history, or drug history. And on examination at the outside center, both eyes had visual acuity of 660. Ishihara failed color vision, failed test plate. The intraocular pressure was normal, no RAPD, and essentially the ocular examination was normal with no diswelling or pallor. So she was extensively investigated at the outside center. So her MRI brain and orbit with contrast was normal. The OCT macula and the peripapillary RNFL were normal. The NMO, MOG, autoimmune and inflammatory markers were all normal as well. So essentially all the blood work was normal. So at this point, what would you do next? So anyone, those who are eligible to answer this question, please feel free to shout out. It's a very small room. So anything you would do. Anyone? Well, it's conceivable that if a patient with retrobulbar optic neuritis, the peripapillary RNFL and everything else could still be normal, and there's still a chance that you could miss the optic neuritis on an MRI. Even with contrast, there's a 5% chance that you could miss it. So at the outside center, they proceeded to do pattern VEP, which was performed, but the results were lost. Honestly, this was how it happened. So when the patient came to me, it was done, but there were no results. So what would you do next? So, as we say in neuro-ophthalmology, nobody is allowed to go blind without a trial of steroids. So she was given a trial of ONTT steroids with IV methylpred with oral prednisolone, but there was no change whatsoever. So eventually she came to us 3 months later, 3 months after the onset. She came into the room wearing sunglasses with her husband, very nervous. I think the neuro-ophthalmologists among us will know the significance of the sunglasses. Anyone else? No? Well, look it up. Sunglasses sign, published in the neurology journal, the Green Journal. So at that time, the visual acuity was 160. She failed the Ishihara test plate. The discs were pink. So I highlighted as pink. And there was no RAPD. This is what her visual field looked like. So at this point, what would you do next? Sorry? OKN. Well, we could do that, but before we do that, I think OKN is actually quite a good a suggestion. But we didn't do that because for those of you who have listened to my talks before, my favorite favorite thing to do is OCT. So I did the OCT. Okay, so this is what it shows at 3 months. So the OCT is entirely normal. So the RNFL is a 90 something, I can't really see it, but as you know, it's green and green, both eyes. So what am I thinking about at this point? I'm thinking this, well, as you know, if you have an optic neuropathy from, optic neuropathy from any cause, you should have signs of optic atrophy, clinically and also on OCT, usually by 2 months after any optic nerve insult, or maybe I should put any in quotation marks. Okay, so at this point I was thinking, definitely this lady, definitely is functional visual loss. I mean, she looks it, the RNFL has confirmed it. So, but at this point, I did one other clinic examination. It was almost diagnostic there and then. Can anyone tell me what it could be? Sorry? Yes. Why do you say that? Perfect. And in which condition does that happen? I think it can happen in toxic sometimes, and in some of the lesions, some of the optic neuropathies with initial diswelling, that could happen. Well, in fact, in a range of optic neuropathies, this can happen. But I think you're completely right. And another of these conditions is actually Leber's hereditary optic neuropathy. So after I saw this, I actually sent off for mitochondrial analysis, and it came back positive for 14484 mutation. So I'm going to spend a couple of minutes talking about how, so why was this so important to me is because studies have shown that in this case series, which was from Dr. Sadoun's group, this is a very important paper to me because it shows that the OCT in this situation can help to differentiate LHON from other causes in that even before the onset of visual loss, you get ganglion cell thinning in LHON. So for a patient who presents with visual loss at the onset with normal RNFL, so even at that point, if you pick up thinning of the macular ganglion cell layer, it will point you towards further, first it will point you towards that this is not functional, but actually organic, and it will hopefully put you in the right direction for further investigations. So I'm going to spend a few minutes talking about the usual and unusual presentations of LHON. So, we've all learned in textbooks that so Leber's hereditary optic neuropathy presents a bit like optic neuritis in that the onset is rapidly involving central or centrocecal scotoma. Usually it gives you the visual acuity of 660 or less. It's always bilateral. In 25% of the cases is simultaneous. In the others, even if it is unilateral in onset, the fellow eye usually becomes affected in the next 3 to 6 months. The optic disc classically is supposed to look like it has pseudopapilledema, so it's swollen, but if you do the fluorescein, there will be no leakage. However, it can look entirely normal, and I've been fooled a couple of times by that. So the peak onset is the 2nd to 3rd decades of life with a male predominance. So your usual patient is a young boy in their teens or a young male in their 20s. So this is the usual presentation. So males have a 50% of losing their vision if they have the mutation, and females is only 10%. And this is the mechanism behind this is not entirely clear. I was really hoping that, I know that Patrick is at this conference, and I was really hoping that he can elucidate us as to the cause of this. The MRI is typically normal in LHON, but LHON can also have unusual presentations in terms of atypical age and gender, atypical MRI findings, and also we can get L-horn plus syndromes. So unusual presentations, we mentioned that it can happen in 10% of females. So our lady of 55 years old female is very atypical, but it has been reported to present in older adults up to 75 years old. It can also present in younger children. So about 10% or less present in children of less than 12 years old. And in a third, it can be slowly progressive as opposed to subacute onset. It can be insidious or even subclinical, so they could have quite good vision. So if LHON presents in younger children, it is associated with better visual recovery. And the interval between the two eyes, although it is always bilateral, the interval can be can be up to 34 years. So in terms of MRI findings, just now we mentioned that the MRI is usually normal, but there's a case series describing MRI changes in LHON patients. So in this case series of 20 men and 8 women, so in about 2/3 of the patients, they actually had T2 hyperintensity in the posterior portions of both optic nerve and chiasm. And in 16 patients, in 16 patients, there was enlargement of the optic chiasm, but there was no enhancement of the optic nerves or chiasm. And 6 patients had non-specific T2 white matter lesions, which were not typical of MS. So the third aspect I want to talk about is the LHON plus syndromes. So it is usually, although LHON is usually isolated, sometimes it can be associated with, for example, dystonia, myoclonus, and there can be overlap between LHON or an MS, and is labeled as Harding's disease. And there can be a spinal cord syndrome with features of NMO, which can be both seronegative and seropositive. So even if you have seropositive NMO, it can still be associated with LHON, particularly in the patients who are not responsive to steroid treatment. So just before I end, I just wanted to give you a progress of this patient 2 years after onset. So her visual acuity had improved from 160 to 660. And the visual field, as you remember initially, it looked like this. So after 2 years, it started clearing up. So this is typical of 14484 mutation. So I'm going to see her again. This is now 5 years in 2 months' time, and I hope I'll have good news for her and for us. So to take home is that LHON should be considered in anyone, whether older, younger, male or female, with subacute bilateral visual loss, whether it's simultaneous or sequential, and those with poor recovery after steroid treatment. So we need to be aware of MRI findings, the optic nerve and the chiasmal enlargement without enhancement. They can have MRI features consistent with MS or NMO, and always order MRI with and without contrast, unless the contrast is contraindicated. And of course, OCT macular ganglion cell layer thickness can be very helpful for diagnosis of LHON in the acute setting. So thank you.